Welcome to this quick medical review on acute heart failure. In this episode, we will cover the definition, epidemiology, causes, pathophysiology, clinical presentation, diagnosis, and management of acute heart failure. Heart failure is defined clinically as a syndrome in which patients have symptoms and signs resulting from an abnormality of cardiac structure and function. Acute heart failure refers to the rapid onset or worsening of symptoms and signs of heart failure, requiring urgent evaluation and treatment. Acute heart failure is a significant public health concern, causing or complicating 5% of all adult emergency hospital admissions in the UK. Approximately 900,000 people in the UK have heart failure. The mean age of patients admitted with acute heart failure in England and Wales is 77.8 years old. The most common concurrent conditions in patients with acute heart failure are coronary artery disease, hypertension, diabetes mellitus, atrial fibrillation, and renal insufficiency. A helpful way to classify acute heart failure is by precipitating factor, as these need to be treated urgently. These include acute coronary syndrome, hypertensive emergency, rapid arrhythmias or severe bradycardia or conduction disturbance, acute mechanical cause underlying acute heart failure, acute pulmonary embolism, infection including myocarditis and tamponade. The pathophysiology of acute heart failure is complex and involves several mechanisms, but most patients will have evidence of volume overload with pulmonary and/or venous congestion. During an episode of acute heart failure, the sympathetic nervous system is activated, causing tachycardia, increased myocardial contractility, increased myocardial oxygen consumption, peripheral vasoconstriction, and activation of renin-angiotensin system with salt and water retention. Vasoconstrictor neurohormones are activated, which leads to sodium and fluid retention, increased myocardial wall stress, and decreased renal perfusion. If not treated effectively, these changes can lead to a vicious cycle of worsening cardiac function and ultimately death. The clinical presentation of acute heart failure can vary depending on the underlying cause and the severity of the condition. Common signs and symptoms include breathlessness, which may be acute but also includes orthopnea and paroxysmal nocturnal dyspnea, ankle swelling, which often reduces when legs are elevated for a sustained period of time, reduced exercise tolerance, fatigue, tiredness, increased time to recover after exercise, elevated jugular venous pressure, third heart sound also called gallop rhythm, pulmonary crackles. The sound of the crackles heard on chest auscultation in heart failure is described as wet and sounding like Velcro. They are usually fine and quiet rather than the coarse sounds heard in lung disease. They can be mistaken for the bilateral crackles of lung fibrosis, but patients with fibrotic lungs are more likely to be hypoxic with exertional desaturation. Less common symptoms include wheezing, dizziness, confusion, especially in older patients, loss of appetite, nocturnal ischemic pain, nocturnal cough. Suspect acute heart failure in any patient presenting with the above symptoms, especially if they have a history of cardiovascular disease. The following investigations should always be ordered: 12-lead ECG to look for arrhythmias, evidence of ischemia, for example, ST segment changes or left ventricular hypertrophy; chest X-ray to look for signs of pulmonary congestion such as cardiomegaly, pleural effusions, and curly B lines; blood tests, which include BNP or natriuretic proBNP. Normal levels make a diagnosis of acute heart failure unlikely, but elevated levels do not automatically confirm the diagnosis. Other blood tests include full blood count, urea and electrolytes, glucose, liver function tests, and thyroid function tests. The management of acute heart failure depends on the severity of the patient's condition. The initial goals are to stabilize the patient's condition, identify and treat the underlying cause, and alleviate symptoms. Patients with acute heart failure should be rapidly transferred to the hospital, preferably to a site with a cardiology department and/or coronary care and intensive care unit. The specific treatment for acute heart failure will vary depending on the patient's individual needs. However, some of the common treatments include oxygen therapy, given if the patient has oxygen saturations is low; diuretics, to remove excess fluid from the body; vasodilators, to reduce the workload on the heart; inotropes to improve the heart's pumping ability. Mechanical circulatory support may be necessary in severe cases. Device therapy, such as an implantable cardioverter defibrillator or cardiac resynchronization therapy, may be considered. After stabilization, patients need to be reviewed by the heart failure specialist team within 24 hours of admission. Subsequent treatment will then be based on measurement of the patient's left ventricular ejection fraction and level of symptoms. Acute heart failure is a serious condition with a high mortality rate. The prognosis for patients with acute heart failure depends on a number of factors, including the underlying cause, the severity of the condition, and the patient's overall health. Predictors of adverse outcomes include hypertension, renal dysfunction, older age, male sex, ischemic congestive heart failure, previous congestive heart failure, respiratory rate on admission more than 30 per minute, anemia, hyponatremia, elevated troponin, elevated B-type natriuretic peptide, other comorbidities such as cancer. Acute heart failure is a common and serious condition that requires prompt recognition and treatment. Early involvement of the specialist heart failure team is essential. This concludes this episode on acute heart failure. Thank you for listening. Join us next time as we continue to explore important medical topics.